you for having me. We know the very insightful work you do in Netherlands, so it's a pleasure really to be here and share our experience. So please, Mary, you can move with the PowerPoint for the next slide. I have already introduced myself. I just will comment very quickly that I wrote a book about a lot of the TDABC projects, and you can find the book in this QR code, so feel free about that. The next one, please.
Congratulations on that.
Thank you so much. I will talk later a little about the book, but you also can have it with you. So I will start with this discussion about what are you trying to measure when we are applying to TDABC. And on this chart, you can see the general proportion of GDP spent by countries in healthcare. This is a macroeconomic number. In any country, is an expressive value. We always have a good investment in healthcare, and we always have an impression around the world that is not enough. So I just would like to share this question with you, that we are really measuring the budget that we have, but we don't know if this is good enough, and we also don't know to answer how much we need. So when we are trying to evaluate costs in the perspective of consumption, we are really looking for this answer, how much we need to deliver high quality care to our population. The next, please.
Doesn't want to go. Yeah.
No. So, and when we try to measure, also what we are generating is a good reference. And I like to joke a little about sports. I run every day, and probably here, part of you also have a sport, something that you practice. And when I'm running and other people that run, we are always measuring time, the pace, something that can help you to tell your friends, your family that you run 8 kilometers in 40 minutes, and this is good or this is not good. And in 1 year, you can say that, oh, I'm improving my running, or I'm the same. I would like to run faster in 2 years, and this is a goal. So we just can tell the history to someone about your sport when you really have a number and a reference to tell about that. If not, to just say, I run. And it's not a lot saying that I run. So measuring continually a process have the same meaning. We create a reference, and using this reference, we always can have parameters with us to report to a small group of people or to the general society if you are doing something well, we are improving or not. The next one, please. And when we start to measure this kind of numbers in healthcare systems, we get super surprised. And this is not something from Brazil, from Netherlands, from Portugal, or from the US. You say that anywhere we can find variabilities, and by measuring the size of this variability, we can start a strategic plan to do something different. And I will use this history about this study to demonstrate the size of this impact we are talking about. But in this case, we really evaluated all the stroke cases from CMS in the US in the years of 2023 and 24. We worked with a huge data set, more than 200,000 ischemic stroke cases from the US. And we measured that in average, a stroke case, a stroke hospitalization can account for a variability of 500% across the states from the United States. So this is not cost, it's just payment, and it's a lot of money. In other words, we are saying that having a stroke in New York is much more expensive than in Houston, for example. So, and at the same time, what is being delivered for patients in New York or Houston is the same. We have macroeconomic influence here. Certainly we have, but it's not enough to justify the size of this variability. And this is something that we can do by applying the TDABC to identify opportunities to reduce this variability. We will not achieve zero variability, but certainly we can work better in reducing that. The next one, please. So is this what we have as a purpose when we are applying TDABC? In this slide, I have a diagram that I use to explain what I understand by value and what we are targeting at the end. And probably you guys, when we're working in a value-based healthcare project, you are also targeting this impact. You are trying to really impact population health. And this I name as a social impact. And we want to do it with a financial accountability. And this is just possible when we really reduce inequity. We use resources in an efficient way. And what can be done to make it happen is to work with value-based agreements, risk-sharing agreements. And this is only possible if you have a good quality on proms and costs. Proms, we know Aishon does a great job in European countries. You guys in Santiago have a very interesting and remarkable, I would say, experience. But when the topic is costs, we don't have a lot of really remarkable cases across the globe. So measuring costs in the perspective of resource consumption is in the same page than measuring proms when we try to implement something different, and a standard way to really evaluate the consumption that people are really registering in the health system. The next one, please. So let's go further on to TDABC. The next one, please. And this is the focus of the class today, and I would like to make a brainstorm with you in terms of what it represents. If we start to evaluate in terms of publications, it has increased a lot, the number of papers using TDABC. It started with this seminal book from Professor Bob and Steve Anderson. At the time was Professor Bob, PhD student. The book is not written for healthcare business. The book was written to really report the methodology. But since 2010, when the value-based healthcare movement started to get disseminated, the method also was really recommended to be the strategy to be implemented in value programs. In 2019, I would say around 2019-20, we started the TDABC consortium. The consortium represents a network of people that really apply TDABC in different countries. Also allowed us to organize a conference in Lisbon in 2022, where we really started this networking of people that implement the method and can, really help each other and do something different. The next one, please. You can go. I already talked about the conference. The next one, please. Well, because of this network and I would say the bottleneck as well in methodological guidelines to apply the TDABC in the healthcare environment, we developed a few seminal and methodological articles. Here you can find part of them. I will highlight the one from BMC, the standardized framework to evaluate the quality of studies using the TDABC. It serves as almost as an Aishon standard set, but is a framework to guide how to implement the TDABC and to evaluate the quality of studies that use the methodology. In Brazil, the last one is in Portuguese because it is the national guideline to perform microcosting analysis in Brazil. This national guideline was written by our group And we really incorporated the TDABC as a recommendation from our Ministry of Health. The next one, please. So how the method is really helping to optimize management and patient journeys. The next one, please. This is the first case I would like to share where we implemented the method not to serve as a tool to measure costs, but much more to guide the identification of bottlenecks and opportunities to standardize a patient journey. This study was developed with 3 centers from Brazil in the field of radiotherapy for prostate cancer. We really evaluated the care pathway of those patients in our public system. And a few numbers that really are not beautiful, but are true. We were able to measure that the length of time between diagnosis and the radiotherapy starts was around almost 1 year. And this was super important to be reported at the time and allowed us to really point out a few recommendations to our policymakers. The next one, please. We started this project with the first step of ever TDABC project. We need to design the care pathway. And here is the full cycle since the primary care arrival, when patients start this journey, until the end of the radiotherapy treatment. And you can see all the activities and people involved and the length of time in days that people spend between the activities. And it allowed us to identify the huge bottleneck that patients have from the primary care to achieve the reference center where they start the oncological treatment. This is here much more to illustrate how by doing a TDABC exercise, we could find a lot of opportunities to redesign a care pathway. And this is what we did. The next one, please. In this project, because we did a design thinking activity and we identified a lot of opportunities that could be implemented in our public system to improve this process. So since to generate an informative book with a dashboard or an app that patients can access, it could help patients a lot to identify and to know that they are in the third or the end of the radiotherapy sessions. We evaluated, we interviewed patients and discovered that they really don't know where they are in the treatment cycle and what's next. And it caused a lot of anxiety and mental issues, I would say. Also, it will be super important to integrate the systems and to have a much more aligned and effective process between primary care and the oncological treatment center. So it was very important to us at the time by designing the TDABC and the care pathway to identify all those opportunities. The next one, please. So this one is the one that you guys really, I think, identified and invited me to be here today. But it represents a national project we did in the stroke field. And we had the opportunity to publish it in New England Catalyst. And what we did as a very different thing here in this project that allowed us to achieve the journal was to really merge the prompts and costs based on TDABC in a dashboard, a business intelligence dashboard. So I really like to tell a little about the history behind that. I was doing my postdoctoral fellowship and we worked with 3 reference centers for stroke in Brazil and also a digital company from Portugal. At the time was Prologica. Prologica is working in Portugal yet. She was is with a new group of directors, but also is working in healthcare market. And as we were developing research to really develop this dashboard, with the clinicians, with the financial people, and with the IT team. It was not something like a researcher working alone and thinking about problems and costs and how we can do very nice charts or this kind of things. We really put together people that will use the information in the future, the clinicians and the financial people, and the IT guys to really recognize what they need to prepare inside the structure to make it feasible. The next one, please. So this is one of the views of the dashboard. Here I have all hospitals, but we could select just one hospital. And what I have in this dashboard, it is the comparison. I will start by the header chart. The header chart I have in each line a different hospital, and I can see the ISHON for stroke measures being compared across hospitals. So it's a benchmark idea. The other charts, the bar charts in the down part of the screen here, I have the mean cost per phase and the length of time in hours per phase of treatment. And I can see that in each hospital, we have different strategies in terms of care delivery. We have a hospital that don't have a stroke unit. And because of that, patients spend much more time in ICU, for example. And it accounts for more money. So we can really start to put those numbers in terms of hours and the money associated in the same view and identify where are opportunities and how can we look for strategies that can standardize and reduce the variability. The upside of the screen here, we have the clinical characteristic of patients. So the mean cost per Hankin. Hankin is a super specific measure we use for stroke. It measures the complexity of patients. So Hankin 5 and 6 is almost 6 is death. 5 is someone after stroke that really cannot come back to speak or walk and is in a very bad situation. So we can see that Hankin 5 or 6 are much more expensive. NIH is another classification associated to the stroke field, and we use this classification when patients arrive at the hospital. And again, we can see that patients with a higher NIH are more expensive. They are more complex. So, this is just an example about the dashboard, how we can use it to identify, to measure the variability and to identify opportunities to standardize care and outcomes. The next one, please. Once we finished the study in Brazil, it gets a little of visibility with the stroke community. And we had the opportunity to amplify the study to Latin America. And this I would like to make a very quick comment because people sometimes have say that a bottleneck about applying TDABC is the capability to work with a lot of centers, a lot of countries, and a lot of patients in our samples. For me, this study is an answer for this commentary because we were able to work with almost 1,000 patients from 8 countries from Latin America. You are now talking about high-income countries with a lot of technology inside the hospitals. We are really being very honest that here we had manual data collection, but we are able to collect a lot of data and to evaluate the variability in costs between Latin American countries. I don't want to go further on the information, but I just added the charts here to demonstrate that in Latin America, similar countries sometimes, but a huge difference in costs. I'm not happy to tell you that Brazil is the most expensive country for treating stroke patients, but this is true, is what we measure it. And this variability is in all types of treatments for stroke patients. The next one, please. Well, I commented at the beginning that I will achieve this integration between TDABC and HTA process. So please, can you go to the next one? And I selected one example, but before I start to tell the history of the example, I just would like to do a very quick comment about our HTA process and contests. In Brazil, we have two agencies to evaluate technologies. The Conitec evaluate technologies for the public system, while ANS evaluate technologies for the private system. And once a technology receives a safety approval, similar to FDA in the US, here we have Anvisa, it can be submitted to an economic evaluation to really assess the market in the future. And most of those economic models are built using a national payment reference, how much the government pay for a medical appointment, for example. And as you probably know, it is not costs. This is how much someone is paying for something, but it doesn't mean that we are really costing what the government or the payer is paying. And in our situation here, what the government pays, the federal government pays for a medical appointment or anything in the healthcare system, is a part of the payment of what organizations receive, and is a super small amount of money. And this is a true example. For example, 1 hour consultation with a clinician in our system, what is being paid by the government is around $3. And how much it costs is around $25. So it's a huge difference, a national problem. It's not a topic for today, but just to exemplify here that a lot of economic models are considering the $3 in the economic model, but not the 25. And when we think about budget impact in the future, it becomes a huge problem. So what we have done in a lot of HTA process is to really bring this information, the 25, because it is not available. It's not a public information. It's what we discover by doing the TDABC, and to update the economic models with a more accurate cost information. The next one, please. And this we started to do a lot in different fields. The example that I have today is in heart failure. Our history with heart failure started in 2017, and we started to generate a lot of evidence, cost evidence in Brazil for treating heart failure patients. Heart failure patients under outpatient care, heart failure patients that were submitted to heart transplant, to very innovative technologies such as ECMO, until in 2024, the HeartMate was incorporated in a HTA process in our country, and with a huge difficult to be approved. And then they invited us to get involved in this history. The next one, please. And we developed this study in Brazil, where we really evaluated a real cohort of patients that will be eligible to HeartMate. And what we were able to demonstrate is that the cost of patients that are eligible but were not receiving the technology in the system was super impressive and important. The numbers here that we have in this screen, it's not here the one, but I can tell you. The first model that was presented, people considered that a heart failure patient will account for around $1,000 a year, and you were able to report that it was really $45,000 per year. So the difference was super large, and it changes the decision. So at the end, the technology was incorporated in our national public system because we really updated the economic model using a much more accurate cost information that was not available at the beginning. So the next one, please. This very similar activity we did for different heart disease in Brazil. Here are 3 examples. In the hemophilia, we collaborated in the HTA process to incorporate the MSC-Zunab in 2024 as well. Muscular atrophy, the medication ursinersen was approved in 2021, also using a microcosting analysis that we worked on to really generate the real cost information and not only payments. For Duchenne, the same thing, but we didn't have a positive incorporation at the end. It was super expensive, but okay, the process was important. So the next one, please. Well, another angle that I would like to explore at the end of our presentation here is the technology. I commented very quickly before that to include a huge sample of patients in this analysis is a challenge. We did for the stroke project in Latin America, but it was not easy. It was super time consuming and a challenge to organize. But the good news is that softwares and technologies such as the one we developed with Prologica in the Brazilian study are already available. In this article we published 2 years ago, we really evaluated TDABC studies using a technology support, a software support to collect data, and the ones that were done only manually based. And the pink chart here is talking alone, I would say, because we can see that the sample of cases we include in technologic-based studies is much more expressive than the manually based. In manually TDABC studies, we in average were including 160 patients, and the technology based more than 4,000 patients. So the technology helps a lot. And the good news is that today it's not so super difficult. 5 years ago, it was much more complex to have good software to collect time data and to really follow patients' resource consumption inside hospitals. Nowadays, the technology is much more accessible and sometimes available inside hospitals, but not being used. In the oncological field, for example, radiotherapy, all the radiotherapy machines have a lot of time data. And we can super use these reports to develop this kind of studies. The next one, please. This is just a few examples in the US. In the United States, a lot of hospitals already have this kind of softwares. This one is a real case from Beth Israel, where they started to implement softwares that evaluate patients' resource consumptions in an individual level, considering the TDABC method. And by controlling the consumption of surgeons, anesthesiologists, surgery room, and materials, they were able to reduce the variability, not only the variability in terms of materials consumption, but the length of time, a lot of variability on length of time that patients spend in operation room and with different surgeons teams. And at the end, they saved around $11 million just by working a lot on the data that is being generated. The next one, please. This kind of technology allow managers to have access to this kind of information. Here, you can have different procedures or different teams doing the same procedure, and you can follow the cost I have in my hospital, the most effective hospitals in the US, the most expensive hospitals in the US. I can do it in a perspective of my hospital in comparison with other hospitals, or inside one hospital, I can compare surgery teams, for example. my team and a surgery team and Maria can have a very huge variability, and by having access to this kind of data, the managers inside hospitals can really develop a conversation and a strategic planning to reduce the variability based on data, and not only on feelings that I think that Anna is spending much more time in her surgeries than Maria. Here we really have the information to guide this kind of internal policies. The next one, please. So with these examples, I really would like to have time to discuss with you and have questions. But I think that it's clear that good quality and capacity in the data measuring process and the establishment of a data-driven policies are required steps to center healthcare systems on patients' needs and drive policies to increase equity, access, and quality in care services with a financial accountability. So coming back to how I started, for me, these TDABC examples, together with PROM's measurement strategies, is how we can really have good data to create a value strategy inside the hospitals. And the technological capability here is a requirement, but nowadays is not something difficult. We have a lot of software and digital solutions implemented in the hospitals, and we can use what they already report much better and use the report to generate cost assessment analysis as well. The next one, please. So, thank you.